ಇಲ್ಲ ಇಲ್ಲ ಎಲ್ಲ ಡಿಲೀಟ್. ಓಕೆ ಥ್ಯಾಂಕ್ ಯು.
being held. This year, the emphasis on changing mindset and power yourself. So I would like to call upon our Director of Medical Service, Dr. Annabel Sekhar, for the opening remarks.
Dear guests, colleagues, and friends, good afternoon and a warm welcome. It's a special occasion today as we gather to celebrate the World Hearing Day with this CME organized by the dynamic ENT department at MGM. The department has been consistently active in both clinical practice and academics, making significant contributions to the field. We also take pride in our audiology and cochlear implant program at MGM, which is thriving under the leadership of Professor Dr. Sanjeev Mohanty. His expertise has been instrumental in advancing hearing care at MGM. I'm sure you will find this CME enriching and engaging, given the department's dedication to excellence. Wishing you a great session. Thank you.
Thank you, ma'am, for your kind words. So let's get into the event with a academic note. Next up, we have Dr. Nisha Megan George, Senior Consultant, Department of Pediatrics and Neonatology, to give us an insight about neuroplasticity and auditory development.
Good afternoon, everyone. Thank you very much, Dr. Mohanty, for this opportunity. So, when Dr. Mohanty told me if I speak at this, I'd love to be the kind of person to say, oh, I've done extensive work, extensive research, I'm speaking for my body of work, but none of that. I am going to be speaking about a topic of which I know very little. I learned as I read, and I think the reason he wanted other departments to speak was because it would raise awareness in us, and we are part of this entire team that we need to know these things because we are part of that pathway down to which a child or an adult gets a cochlear implant. So thank you, Dr. Mohanty, because this opportunity helped me to realize a lot of things about which I knew very little. So without much further ado, I'd like you all, before I get into my presentation, to just close your eyes for a minute. Humor me, please close your eyes. So what you experienced was this beautiful thing that we have that we all take for granted. The ability to hear that gives us this fantastic thing called music. It transforms moments, it transforms lives, it transforms every situation we're in, it can transform our mood at every point of time. And that is because we take for granted the fact that we can hear. This was one of the most poignant things I understood as I read and I prepared for my talk. So without further ado, let me go ahead. I'm going to speak to you about neuroplasticity and auditory development. Before we go talk about neuroplasticity and auditory development, let's take a few steps back because most of us in this audience would like to come back a little bit back to the basics and understand more. Okay. So the overview of my presentation is going to be what it takes to hear the anatomy and physiology of hearing, pathological changes in anatomy and physiology, the embryology and development of hearing, what is neuroplasticity, and what do we know about neuroplasticity in auditory development. So this exquisite organ called the ear, simple but extremely not simple at all, actually very complicated and exquisitely placed in this features part of the temporal bones. It does a lot of amazing function. So that's where it's situated. As you can see, in the features part of the temporal bone, just within the ear canal and then extending in and connecting with the central nervous system. So what it takes to hear? We know that in the anatomy of the ear, there are three parts: the external ear, the middle ear, the inner ear. Each of them has its own special role to play in the whole hearing process. So let's begin with the external ear. The external ear extends from the auricle to the ear canal and finally finishes at the tympanic membrane. The auricle and the ear canal, especially constructed, we think these are made up of helices and this complicated shape is for no reason. It is for a reason to take all the sound waves into the auditory canal. Second, next is the middle ear. So at the tympanic membrane, from the tympanic membrane starts the middle ear. Now this just a few more things about the external auditory canal. So its biggest function is to collect all the sound waves and send it into the middle ear. Now this auditory canal also contains the ceruminous glands that also produce cerumen. Cerumen has a great antibacterial activity. So the wax that is produced is actually got a very strong antibacterial activity. Then we go on to the middle ear. Now this middle ear is, as you can see, it starts off with this tympanic membrane. This grayish translucent tympanic membrane is the one that transmits the sound waves from the external or the external ear to the inner ear. Now this middle part of the ear is called the vestibular cavity or the vestibular part of the ear. And this consists of three ossicles: the malleus that's shaped like a hammer, the incus that's shaped like an anvil, and the stirrup, the stapes, which is shaped like a stirrup on a horse. So the malleus, the incus, and the stapes, all extremely small bones. The malleus is connected to the tympanic membrane, and it is because of this connection that the tympanic membrane is stretched taut. So the tympanic membrane has two parts to it: a very taut part and the the pars flaccida, which is the flaccid part. So going forward, the malleus incus stapes, the sound waves are then transmitted. Now this sound is best transmitted through solids. So it is transmitted across these three bones, and these three bones amplify the sound 10 times from when it is received. Also in this tympanic cavity are two muscles, two important muscles. One is the tensor tympani muscle, which is connected to the tympanic membrane and has a very, very important function. The tensor tympani muscle prevents the tympanic membrane from undergoing extreme vibration in the time of very loud sounds. In addition to the tensor tympani muscle that stretches over there, you also have the smallest muscle in our body, which is the stapedius muscle. The stapedius muscle is at the bottom of the stapes. Again, the function is in the presence of very loud sounds, it doesn't want to allow too much vibration and therefore protect both the tympanic cavity and the bones. So crossing over the middle ear, we go into the inner ear. Now, the inner ear is the crucial part of the ear that has two functions. Most of this inner ear is used up in the function of balance, and part of it is used up in hearing. So the inner ear is made up of three parts. As you can see, semicircular canals, vestibular part, and the cochlea. Going from anterior to posterior, the cochlea, the vestibule, and the semicircular canals. So this inner ear is also called the labyrinthine cavity, and this labyrinthine cavity contains across the entire labyrinthine cavity there are two parts. This is the one that is so the middle and the inner ear are both contained within this features part of the temporal bone. Now this labyrinthine cavity has got two parts: a bony part and a membranous part. The bony part is almost like it protects this membranous part. Between the bony and the membranous part, there is something called perilimb, and within the membranous part is endolimb. Now, each of this is so you have the central vestibule, and then there is the semicircular canals. These semicircular canals are beautifully designed, three of them, to allow your head to move in three different planes. You have the superior semicircular canal, the horizontal semicircular canal, and the perpendicular semicircular canal. So the superior one allows you to nod your head up and down. The horizontal one allows you to move it from side to side, and the perpendicular one allows you to move it and touch your ear to your shoulder. That kind of movement it allows. So these semicircular canals are connected by these enlarged parts called ampullae to the central part. Now these semicircular canals, the other side is made up of the cochlea. At the ampullae of the semicircular canals are these fine neurons that these are responsible for maintaining this balance. Often seen, these neurons have these deposits, which when there is a small change in that is what causes this benign the BPPV that we often see. Then going forward to the right side, the cochlea. Now that is the organ of the part of the ear that we are interested in as part of the CME. The cochlea is constructed in the shape of a snail shell. 2.5 circles of the snail shell. It is beautifully constructed again. Outer bone, inner membranous part, separated by endolimb. So this is the cochlea. The cochlea curls around like that. Semicircular canals actually form the back, the cochlea. And then the nerves that extend from both the cochlea and the vestibulum form the vestibular cochlear nerve that goes to join between the pons and the medulla. Now the inside of the cochlea is what we are very concerned about, because that is what gives us this. This is the final organ that actually gives you your hearing. It's called the organ of Corti. Now the organ of Corti, here is the bony part of the cochlea, which is forming the beautiful 2.5 circles. Then within that, you have two supportive structures. Now these supportive structures actually are there to protect the organ of Cottai, which stays in between. The structures are the scala tympani and scala vestibuli. These go traverse down the entire extent of the cochlea till the end, and then they meet up at the end. So fluid moves. They contain perilymph. This contains endolymph. And finally, in this organ of Cottai, you'll see those green colored hair cells. These multiple hair cells, these are the ones that pick up sensation. The cochlea is in the snail shell. One end is broad, the other end is narrow. But the hair cells towards the broader part are the ones that pick up the more low pitch sounds. Towards the end are the ones that pick up the finer sounds. So so this is another description of the cochlea. It's a cut section where you can see the organ of Cottai. So what does it take to hear? So the mechanism of hearing, you have sound waves that pass through the external auditory canal, touch on the tympanic membrane. The tympanic membrane vibrates, putting into motion the three ossicles. All the three ossicles transmit sound across them, magnifying the sound 10 times. And finally, the sound transmits through this oval window into the cochlea. The cochlea, and it transmits this perilymph goes down one end of the cochlea, turns around and comes to the other end and opens out to this round window. The purpose of doing this is so as it does this, the organ of Cottai, which is in the central part, are stimulated. The nerve fibers are stimulated, and that is what transmits this hearing sensation. So the hearing sensation is carried by the vestibular cochlear nerve up the nucleus of the vestibular cochlear nerve is somewhere between the medulla and the pons, and it goes up all the way up to the primary auditory cortex. Primary auditory cortex is situated at the temporal lobe, the upper aspect of the temporal lobe. So this is what causes us to hear sounds. Okay. So what are the pathological changes that happen in this whole process of this anatomy? In the external ear, you have a lot of congenital anomalies, and because congenital anomalies affect external and middle ear, we have microtia, and then trauma can affect the pericordial layer. Then the middle ear can be affected by acute otitis media, acute and chronic fluid in the middle ear affects hearing. So all of these affect hearing. Then the inner ear. So this is where it makes sense of why children turn deaf. Congenital rubella and CME cause destruction of the fetal cochlea, especially of the organ of Cottai. That is what causes congenital deafness in these children. Meningitis connecting the perilymph and the CSF. Meningitis, the perilymph is affected, damaging the cochlea and causing deafness. Meniere's disease, PPP, dislodgement of the otocornea, ear rocks of the utricle causes PPP. Presbyacusis. As you grow older, there is a degeneration of hair cells, and this causes presbyacusis. And prolonged exposure of sounds greater than 85 decibels also affects hearing because it damages these ear cells. So this gives us a picture of what all results in damage to cochlea and therefore damage to hearing, therefore affecting hearing. Then going somewhere down the pathway, because we are trying to understand, okay, hearing, what allows hearing to happen, and then what is the embryology of hearing? Where did this all start? So why do children get affected from the time they are born? So development starts from 3 weeks. Predominantly, there are different parts of development. Ectoderm, that's where the first sign of the hearing starts, where there's an otic placode and causes 6 ridges. These 6 ridges complete by 20 weeks and form the external auditory canal. Then the middle ear is caused by these ridges. Now this next to the normal sacrum, the ectoderm becomes little sacules called otic vesicles, and these otic vesicles are what form the inner ear subsequently. This otic vesicle forms a saccule, the cochlear duct, the utricles, semicircular canals. They're all caused by these otic vesicles. And then the middle ear, the external auditory canal and the middle ear, they are formed from the mesentery. These two are formed from the ectoderm. Next rest is formed from the mesentery. So all of this happens by around 20 weeks. And this is also a description of what actually there are the pharyngeal pouches, and from the first pharyngeal cleft is what you get some of the two of the bones, and there's second from the third pharyngeal. This is the description of the aortic vesicle forming into the very important cochlea. So abnormalities in embryology, congenital deafness, genetic, a lot of environment, congenital rubella virus affects the organ of cortex, especially before 20 weeks, and this causes congenital deafness. So what is neuroplasticity? Finally, coming back to neuroplasticity. So what is it that we need to know about neuroplasticity? So you have children who are affected at these various times with affecting their organ of cortex and therefore causing hearing loss. So defining why is it relevant to talk about neuroplasticity, you will understand both in my talk and in the subsequent talks, because it's the ability of a neuronal groups to adjust their function based upon input. It is present throughout a human's lifetime. So this neuroplasticity, it allows neuronal groups to change function, adjust their function, and it is present throughout a human's lifetime. But the potential for neuroplasticity appears to be maximum in the cortex. And development of this cortex depends maximum in the early years. So what has been found is what happens is the maximum amount of neuroplasticity and the development of the cortex happens within this 3.5 years of life, within the first 3 years of life. So there's a lot of cortical connections and synapses that are forming, auditory, visual, and prefrontal cortex, and an overabundance of synapses and causing extensive myelination all at this time. Now that is why the family should be told that this is the time where you need to provide a child with multiple amounts of input, because what they hear will decide how much cortical, how many synapses are formed, what's the myelination. So it's the environment that affects a lot of this myelination. After 3.5 years, there's a lot of pruning that happens. Pruning is found to happen because of once the cortical connections that are not used so much, are multiple, not as efficient, they are all pruned after the 4 years of age. But this does not mean, so they've done multiple studies to understand this neuroplasticity. What all affects neuroplasticity? The relevance of this is because therapy, your using of your cochlear implants and how you stimulate children's hearing, how you stimulate adults' hearing, all matters based on this neuroplasticity. It's telling a brain that has not been used to doing something, will it pick up the function later? So to understand, yes, maximum time of neuroplasticity is the first 3.5 years of life. A lot of it depends upon the environment you provide to the child. So that is a very crucial auditory, visual, and prefrontal cortex. Lots of synapses are happening. Then the other factors that affect neuroplasticity, genetics. Environment is a very big factor. Then there are two parts in this neuroplasticity. There's called a sensitive period and a critical period. It is important to know in every amount of neuroplasticity, the sensitive period is when neuroplasticity is at its maximum. So providing an adequate environment to this child will cause maximum amount of neuroplasticity, maximum amount of changing or creating of new cortical connections, neuronal connections, synapses. This is a sensitive period. Then there is a critical period. The critical period is also important to know because after the critical period, no amount of stimulus production will change this neuroplasticity. And going, so I have talked predominantly about children and this maximum sensitive period and critical period, but they've also done studies in adults and found that they've done studies of adults who have lost their hearing and then provided with hearing aids, and they found that even up to 4 to 6 weeks after start using cochlear implants or any stimulus that they found that adults develop a lot of cortical connections. So they found that among the adults and hearing loss is a very predominant part among adults. but still, and many of them, considering the percentage of people who have hearing loss, a very small percentage actually resort to correcting their hearing loss with any other device, either hearing aid or any other implantation. But they found that within 4 weeks, there is a change in cortical structure based on this, based on the correction, and thereby providing an environment, thereby providing sensitization with auditory stimulus. So, in summary, the anatomy and structure of the external, middle, and inner ear and the various factors that can affect it and embryology and data, it's good to know. Neuroplasticity is present through the whole of human life, but happens maximum in the cortex. And understanding the factors that affect neuroplasticity matters in therapy. Understanding the factors including the sensitive period, the critical period, and that neuroplasticity happens through the whole of life. And a very important part is to know that maximum neuroplasticity happens within the age of 3.5 years. So children with congenital hearing loss, it is best to provide them with input before that, before in the sensitive period, so that they have maximum stimulation of the cortical connections. Thank you.
Big time. Thank you, Dr. Nisha, and very extensive and good little revision for all of us. Just to add on to what you said, the critical period 3.5 years, probably I don't know from which next we've taken it, probably even lesser, 3 years. Okay. So the sooner you try to get into this mode of getting them pictured as one of the probable candidacy, the earlier the better. That anyway we're going to talk about it. The third part, sensitive, critical. The third is period of deprivation. The period of deprivation of any auditory input, whether it is maybe after say sudden sensorineural hearing loss, maybe a viral infection, or for that matter, if you have somebody who's had bout of meningism, those candidates for the patients, it's best to do some kind of auditory input to force the cortex, the prefrontal gyrus, as well as the visual inputs that we're talking about, when they try to get within 90 days, within 3 months. And then to buy time, like initially you can't buy a full-fledged stuff. So if some amount of inputs by hearing aids, some talking, gibberish, doesn't matter. The brain needs to know. Just wanted to very sensitive. Thank you very much.
Thank you so much, ma'am, for your insightful presentation. Also, thank you so much, sir, for adding on. So now we have Dr. Deepthi, Associate Consultant, ENT, Head and Neck Surgery, to talk about beyond hearing aid, what next? Very good afternoon, everyone. So beyond hearing aids, what's next? That's what we're going to talk about today. What are hearing aids? They are basically battery run sound amplifying devices that will amplify the sound, and this amplified sound has to go the normal auditory pathway. It has to go through the tympanic membrane, middle ear, inner ear, and then to the auditory nerve. So, what are the limitations that we face with hearing aids? There is limitation in speech recognition benefit that we have. Also, patients experience inefficient gain or amplification. There is feedback. What happens? The sound that is amplified is picked up again by the hearing aid, and that causes a kind of a low frequency hum in the background, which can be annoying. Also, there is distortion. Not all frequencies are amplified uniformly by hearing aids. Because of that, the timbre and the bass is lost. That is not a very comfortable thing. Patient has to go for frequent follow-up to fine tuning. They have discomfort with loudness, and ear mold can be uncomfortable for few patients. All of these reasons make them unhappy and frustrated, leading to either not having adequate benefit from the hearing aid that they purchased or not using them at all. So, what do we do next? We have multiple options. As I already told how the hearing aid works, we have other options like implantable hearing aid. This is best used for children with an impaired. Whenever you have an issue in the outer ear and the middle ear mechanism, we can use a implantable hearing aid. And say you have an issue in the cochlea, so you use a cochlear implant. I'll get into detail of all of this. So this is actually a journey which begins by identifying that yes, I have a hearing problem. You start off with hearing aid, but all of the other devices that I mentioned, the first step is going to be a hearing loss. And based on each patient's comfort, the type of hearing loss, the socioeconomic status, and the lifestyle, their qualification, the work that they do, multiple options are available, and each patient's journey is going to be different. So we'll first talk about implantable hearing aids. When do we use an implantable hearing aid? Basically, when a patient has an issue in the middle ear and external ear. When you want to surpass this issue, use an implantable hearing aid. So either they would have failed using a conventional hearing aid, or they have some kind of a middle ear pathology, say a chronically discharging ear, photosclerosis, or if they have undergone a radical mastectomy. Yes, all these things can be solved with a surgical intervention, but if they are not willing for a surgery or if they are not fit for surgery, then we can think of an implantable hearing aid. So, somebody with, and in coming to pediatric age group, oral congenital atrasias, these candidates are very good for implantable hearing aids. So, when you do an audiometry, you have a conductive or a mixed hearing loss, but the threshold has to be less than 55. You should have a good cochlear reserve because you're depending on the cochlea to conduct the sound waves. Also, a good option for people with single-sided deafness. So you have one ear which is having a profound hearing loss, but the contralateral ear has a good cochlear reserve, say less than 20. Such people also can be considered because when you use an implantable hearing aid, there is transcranial transmission. That is, the contralateral ear is also getting the sound vibration, and through that you get a stimulus. The age for implantation, according to FDA, is about 5 years for implantable hearing aids. So how does this work? You have an external processor and an internal component. So the external sound processor has a microphone, it picks up the sound waves, and then you have an internal part which is transmitted to the internal component by transcutaneous transmission. And the internal implant has a titanium fixture. This is implanted surgically into the skull bone. This osseointegrates and forms a permanent bond. So when the sound wave is transmitted to the microphone, it's picked up. The processor will convert it. The transmitter will convert it to vibrations. This vibrates the titanium fixture, and this is transmitted to the cochlea. So what do you do until 5 years of age when the child is waiting to be fit for a candidate to be an implantable hearing aid candidate? You have non-surgical wearing options where you have a soft band or a sound art which can be placed externally until the patient is ready to get an implantable aid. Then coming to cochlear implants. So what is cochlear implant? In a complicated manner, it is a prosthesis which it has an internal component which is linked to the cochlea, and that stimulates the auditory nerve, which is again coupled with an external component which fixes the sound waves, convert into electrical energy, and this is how the whole process works. Simplified manner, like how Madam told, we have hair cells in the cochlea. So the hair cells are damaged in certain candidates. So the main function of the hair cells is mechano-electrical transduction, converts the mechanical energy to electrical energy. That is what a cochlear implant is. So when that function is lost in a ear, that's where this comes into picture. So again, this has two components. You have an external component and an internal component. As you can see, the external component has a speech processor and a microphone. So the microphone picks up the sound waves, and the speech processor converts it into electrical signals. You have two options for this as well. Some patients are not happy having something behind the ear. So this case which is there behind the ear contains the microphone and the processor, battery, and all of that. There is another option, that is the last one. It's called off the ear, where all of this component is housed in a single case, which need not occupy the space behind the ear. So the opina is free and it can be hidden. It's more cosmetically accepted. So this is the external components. And you have a transmitting coil which is placed on the skull externally. This is attached internally by a magnet. The internal component has to be surgically placed. That has a receiver stimulator that receives these electrical signals and transmits that into an electrode array, which is surgically placed into the cochlea. So just a brief of how it works. So hearing aid, I think I've explained. We'll directly go to the cochlear implant. Yes, so whenever you receive any sound wave, it's picked up by the microphone. Okay, so microphone sends it to the processor. The processor is picking up these sound waves, converting it into electrical signals. And this is transmitted via a coil. And the part that you can see behind the skull, yes, now it's gone to the transmitting coil. That is transmitting it into the receiver stimulator, which is implanted. And that transmission goes into the electrical electrodes, which are placed within the cochlea. And that stimulates the eighth cranial nerve directly, bypassing the cochlea. So there is something called a hybrid electric acoustic stimulation. So you have two modes of stimulation. The mode of stimulation in cochlear implant is electrical, but there are certain patients who have very good hearing, mild to moderate loss and low frequencies, but in higher frequencies they have severe to profound loss. So in these patients, you can use something called the electric acoustic stimulation, which is a hybrid method. You have a single microphone, it picks up the sound wave, and then the processes are two different. You have an acoustic processor which will just amplify. Basically, it's a hearing aid plus a cochlear implant together. So you have both advantages of. So whom do we implant? Do we do a cochlear implant and everybody with the hearing loss? No, there are clear-cut guidelines. So for adults, anybody above 18 years old, moderately severe to profound hearing loss, and when they have a speech recognition score of less than 50%. So initially, I think when the implants were approved, it was 90 decibels as the criteria. Now it's all fine-tuned to up to 55 decibels. Coming to children, as ma'am has spoken about the importance of neuroplasticity, when I think 1990 cochlear implant was approved for kids, it was 2 years, and then in 2000 became 1 year. Now the current guidelines is 9 months, so which is a very good move done by the FDA. So the earlier the better. For children 9 to 24 months of age, profound sensory neural hearing loss in both ears, and again, limited benefit from binaural amplification. So everybody undergoes a trial of hearing aid. And 2 to 17 years, severe to profound sensory neural hearing loss in both ears. Again, limited benefit from binaural amplification. How early is early? So the age of implantation is very important for language development. Auditory linked acquisition of language, that is very unique to humans. We learn to speak by listening. So, habilitation or rehabilitation is not just limited to hearing, it is important for the child to develop even speech. Coming to adults, there are a lot of functional red flags. So not all patients with hearing loss can need to go to an ENT first. So as physicians, anybody or in your family, relatives, anybody who's having difficulty talking over phone, they find it difficult to understand speech with a lot of noise. Socially, there is a sudden withdrawal in their interactions. All these are red flags to get them hearing assessments done. So that will be the first step. When you refer a patient for a cochlear implant candidacy, evaluation, anyone with a sensory neural hearing loss with a better ear hearing, average less more than 60 decibels, is a referral candidate. Also, someone who cannot understand 60% of the words in their better ear. So these are important points that we need to keep in mind. So when you're counseling anybody with a hearing loss, you first send them for a hearing aid. But anybody who fulfills these two criteria, you should also send them for a cochlear implant candidacy referral. Single-sided deafness. So a patient who has a unilateral hearing loss, say for any reason, it could be trauma, any viral infection, why do you need them to undergo a cochlear implant? 1 year is perfectly fine. The advantage will be they have better speech understanding in the background of noise, better localization of sound, and that improves their quality of life and the effort to listen. Because if the sound waves are coming from the opposite ear, it is difficult for them to understand and comprehend the same. So if you look at how the cochlear implant has developed over the years, initially it was done only for unilateral adults who had bilateral profound hearing loss. Then we started doing it in children, unilaterally implanting children with bilateral profound hearing loss. Unilaterally implanting candidates who had other disabilities. Initially it was only hearing disabilities. Now we have our candidates with other disabilities. Then we started implanting bilaterally because as years progressed, the advantage of binaural hearing became more relevant and understandable. And now implanting recipients with more residual hearing. So how does this, once you identify a patient as a recipient, as a candidate for cochlear implant, it's just the beginning of the journey. So first you do an audiological evaluation to see if they fulfill into the criteria, to know what is the baseline that we have. Medical assessment is done. Yeah, that is done to look for the fitness for surgery, radiological evaluation, HRCT, MRI, both complement each other, both are done. We also get an evaluation by speech and language therapist to have an idea of the existing functional use of language of the child or the adult. That helps planning the habilitation process better. And the most important part is counseling. Counseling is a teamwork. You have to involve the ENT surgeon, the SLP, the patient, the family members, the support givers, all of them, because they should have realistic expectations from the implant. Strong family support is very important because in fact, getting an implant done is not the end of it. Rehabilitation is more important. So as I already discussed about the significance of early verbal therapy. So we have a well trained SLB team here, so they take care of it, and also we have for the candidacy criteria that I mentioned, we have a checklist here that we follow with Cerner's device in MGM for all the candidates who are fully fitting into that criteria. So I don't think I have to again emphasize on the importance of a cochlear implant. It's already clear. What's next? So we have totally implantable cochlear implant. The issue with cochlear implant, a few patients face is cosmesis. They want to hide their deafness. You have to take off the external components when they're sleeping in shower. So all those things can also be, handled by using a totally implantable cochlear implant, where even the external device is implanted. The last option. So what do you do when even the cochlea is not functioning well? The cochlea is the complete aphasia. Cochlear nerve is aphasia. Then, even then, we have an option that is called auditory brainstem implant, which directly stimulates the cochlear nucleus complex. But here, again, the expectations have to be realistic. Speech recognition is not achieved in most of the patients. Awareness of sound would be a reasonable goal that we can expect from such implants. I think with that, I will conclude. Thank you.
Going to add on to whatever she has very beautifully elucidated all the details. Just two or three things for the ones who are ENT surgeons and the audiologists and professionals here. After hearing aids, what? If they don't work, there are still some hearing aids which can be implanted. So implantable hearing aids is one of the options if it comes into the criteria. And if that also fails, then you have the other options that is mentioned about the doctor implant and all that. Now, totally implantable hearing aids, the cochlear implant was an experiment which was undertaken about 15 years back, and the results were not very good. So, because we a little blinded with how it's functioning, and we know how important is the follow-up of a patient who's already been implanted, not only for the language and the speech acquisition, also how is the electrodes functioning or not is after electronics. So we want to be very careful about it. Thank you, I think it was very nice.
Thank you so much, ma'am. I truly appreciate the knowledge and perspective that you have shared with us today. Also, thank you so much, sir, for kindly adding on to the presentation. Now, I would like to call upon Mr. Mohammed Ilyas, a senior implantologist, ENT head and neck surgery, to give us a talk on evaluation of hearing aids, evaluation of hearing loss for cochlear implant.
Good evening, everyone. Thank you, sir, for the opportunity for taking this platform to share insights about the talk about cochlear implantation, and I also thank my delegates for coming all the way from their own centers for taking this today. So on this World Hearing Day, we are commemorating this special day on March 3rd. The reason why we have selected this March 3rd is 3 decimal years, which was decided by WHO in the early 2000s. Just happened on particular conference Beijing, China. Starting with my presentation, I'll be dealing about a few of statistics and the Universal Newborn Hearing Screening Program at MGM Healthcare, followed by what is the importance of test battery approach we do at MGM or CI Henderson. So start with a little of statistics. Over 5% of the entire world population has designated hearing loss. That around maybe in India it has significantly to do with 6.3%, which is respect to in general. Whereas when it comes to congenital hearing loss, it was nearly 2%. So it's the reason why WHO has mandated a screening protocol which has to be done in each and every hospital. Which has to be identified before the age of, before the month of 3, and it has to be intervened before 6th of age. Later on, this position statement has been staged, and it has been given like 1, 2, 3, identifying identification has to be done by one, and candidacy has to be done by two, and intervention process has to be done by three. So what we do at NGM Healthcare is we have this divided into two different protocols. One is healthy baby, and the other one is high risk babies. So, irrespective of whatever the number of days of stay in hospital, we do this OE screening for each and every one, maybe during the initial 24 hours of age or in 24 hours of time after birth, or maybe before discharge. Whereas when it comes to high-risk babies, we do generally two tests. One is to focus on OE, and the other one is to do with AABR. I'll tell you why we do two tests for high-risk babies in upcoming slides. So why we do this, when, who, I'm not going into detail. Obviously, the reason behind this presentation is to identify them very early and to intervene them at the earliest. Just because what our previous presenter said, like with respect to sensitive period and critical period, it was a quick question, Dr. Nisha, it was a good presentation. And anything with respect to intervention, yes, we have to start at the earliest. As Dr. Deepthi said, we do have options with respect to hearing aids till if a subject or if a child or adult has a hearing loss up to 90 decibel, if the hearing aids are not helping them, obviously we do have cochlear implants. So where do we do this? Either in the acoustically treated audiology school, or we sometimes bedside with having a minimal noise, ambient noise center. So this is a small video. I just wanted to show this. Not even takes 10 seconds to complete the testing. So this is how we do at healthcare. So once this acoustic fit, meaning hermetic seal, has been attained with the baby, the testing starts. Why I'm showing this is this is the first test which baby, each and every baby undergoes in their lifetime. Once this, just look at it, we do check frequencies between 2000 hertz to 5000, 5000 hertz, because this was the frequencies which used to develop in the initial stage. So this testing has shown pass. This is what it is. But the negativity, I mean, the contraindication of this test is appearing on the upcoming slide. So this was the reports which we used to give to the patient. What you have to look for is, when you see this reports, this category, this SNR value shows that if it is more than 6 decibel, it is pass. But this pass doesn't mean that the baby has normal hearing, nor this refer result doesn't mean that the baby has hearing loss. I'll tell you why. A little bit about OE, self-audit, and MGM. Since this inception of MGM, we have done nearly 1,102 babies. In that, initial reference was nearly around 450. So we were at a doubt like whether this baby actually has a hearing loss or not. But when we did this review testing after 2 weeks of time, everyone gets passed. Maybe because of the dirt particles, or if maybe because of some any medullary component, this eventually gets resolved during the first review. So that's the reason why we do this newborn hearing screening, but still we lack at sometimes because we have to do this AABR testing. When it comes to ANSD, maybe Dr. Sanjeev Mohanty will be speaking about this outcomes of parental implantation. When it comes to certain population like ANSD, we have to do both OEE and AABR. Only then we will be able to identify whether the baby is actually normal hearing or not. So as I said before, this is the entire auditory apparatus. None of the single tests is going to cover the entire auditory apparatus. We do have different tests which is responsible for different anatomical areas. So right now we have started with OE, and I'm now moving on to the AVR family. So this is what we call as like OE in ecology. It is a test which covers only cochlea, and OE covers the part of the cochlea. Whereas AVR, AMS is screening and diagnostic test which tells about information from low brainstem. And MLR, LLR, CE, PP300, these are the corresponding respective tests we used to do at our cardiologist suite. So in clinical practice, ECOG, AVR, and CEPs are much more common to rule out whether this is a patient for CI, cochlear implantation, or whether it is contraindicated for the cochlear implant. And among audiologists, as my colleagues are here, this is a gold standard test, objective evaluation to extract audit information, and none of the AVR tests or none of the AVR family is a test of hearing. It is just a test of synchronicity, which tells about the information of stimulus reaching from the, getting it from the medulla and sending it to the auditory. I'm not going to go deep into this. We are using this, we are doing this testing each and every day in the engine, ENT department. We used to retract information with respect to peaks, just like what we get in thresholds and Puritan volumetry. So if you're able to get threshold till the lowest level of intensity, meaning 30 decibel, we used to name the kit as normal hearing. So this is just a little bit of procedure. Let me cut it short. The running time for the ABR, if the baby cooperates well, it is roughly 20 minutes, along with pre-requirement of sedation, which will be coordinated through pediatricians. So this is how the report looks like. If you are able to get peaks to 30 decibels, we used to name that baby or he or she as normal hearing. And apart from this, what we have to look for is the number of speeds which we have done. So if you wanted to validate the report, the artifacts which we use to calculate it has to be less than 5% of the total speeds. So if it is more than that, we cannot take that particular peak as a valid. So, and the next graph shows that the profound hearing loss, there was no absolute even at 20 decibels. This is actually a potential patient for cochlear. Moving on to ADR and OEE, so this is where we came, this is one of the baby which we have done in MGM, sir. So initially, when we did this OEE testing, it was actually passed, but in the subsequent testing, this baby ended up with having ringing sensation, ringing pattern with absent wave. So this indicates clear cut indicates ANST. We are not debating here with respect to whether it is a pre-synaptic or post-synaptic, but it is a clear cut case for ANST. So as we all know, impedance audiometry, only thing which we have to be very careful is when we get an abnormal results, just like apart from normal A type tympanogram, if there is any C type or abnormal B type, we have to, it's the responsibility of audiologist to tell surgeon that this has to be carefully reviewed before the surgery. So to conclude, objective tests, these are the tests which we do here, but it is not like not all tests are performed for all children. It just depends on the information what we are actually trying to look on. So moving on to the subjective, I'm not going to go deep into this, but these are the tests. Behavioral observation audiometry, visual reinforcement, conditioning play, pure audiometry, speech, and all those things. But what we do in our general practice is basically to do with BOA or pure audiometry, or sometimes conditioning play audiometry. So this is how the environment looks like. We need to have one examiner among the child to just look on the responses if the child gives when we present a stimulus. Visual reinforcement audiometry, if the baby is head controls is achieved, maybe we can take that threshold as a reliable one because what we hear as an audiologist look for is reliability of the responses. Only then I can tell my surgeon that yes, this child lies under this category and this child needs so and so reinforcement or so and so treatment. Conditioning play is just like that. One any kid who can able to comprehend our instruction and who can do this testing efficiently, we can do this test. It is just to mimic pure audiometry. I'm not going to go deep into this pure audiometry, as we are all aware. What we have to look for is any candidacy who go beyond severe to profound hearing loss, but who are not getting benefited from conventional devices like acoustic amplification, even with stronger devices. They are a candidate for cochlear implants. We are speaking here very specifically for cochlear implantation. These are the reports of MGM looks like. So one is to tell you that baby has, this patient has normal hearing. The other one is profound hearing loss. But this particular patient is getting benefited from the hearing aids roughly around 60%, because the scores, the aided scores are roughly around 65 to 70 decibels. So they'll be doing it comparatively better than speech audiometry. It's the gold standard test. Instead of intervening the entire area formally, if you could do this total audiometry along with speech audiometry, we can get more information, because the ideology of this testing is to identify whether the individual can be able to comprehend the command presented and understand and can be able to reply or not. So in speech audiometry, we do several sub-tests. I'm not going to go highlight on this, but this is mandatory in CD candidates. So the normal good scores correlates more than, SIS score, speech identification scores will be more than 95% if the patient really has real normal hearing. So the importance of test battery, what are we going to get from this testings? If we do one or two tests more than it, each test is sensitive, as I said, it takes information corresponding to respective areas. And it helps audiologists and surgeon in such a way that whether to identify whether it is a purely middle ear issue or it is a combination of both, and to differentiate whether it is cochlear or retrocochlear, and to identify whether it has a site of lesion, and it helps in precise treatment plan, and also eliminates false positives. And to conclude, this was the recommendation given by a statutory body named called CB, Cochlear Implant Book of India, which was given in the three format. One is on mandatory, second one is recommended and optional. I would suggest to each and every colleague of my people who are being here to, I think we have to go ahead with this, all of the testings who are being noted as mandatory. And we also do this sometimes ASSR because our brain is more tuned towards modulated tones. Once the brain is able to differentiate the modulated tones, I think that the candidate is doing really good in terms of uh, acquiring this stimulus. So apart from this audio skill evaluation, it is also mandated to send the patient towards speech and language evaluation, psychological evaluation, and occupational therapy evaluation. Because we need to rule out any other behavioral issues or any other psychological issues to basically practice to be validated. So with this, let me wind up my session. Thank you, sir. Thank you so much for.
Well, thank you so much for taking the time to share with us today. You've given a detailed protocol about the evaluation of hearing loss for cochlear implantation. So now I humbly request Professor Dr. Sanjay Mohanty, ENT of head and neck surgery, to share his experience on outcome of bilateral simultaneous cochlear implantation across age group in our MGM premises.
Thank you very much. At the outset, let me put it on record, a couple of things, It is not only my team or our department. It is the audiology wing inside MGM and our friends outside the Astra Hearing Care and the Cochlear company, which has worked in tandem to reach where we have reached in terms of the outcomes of patients and also the constant follow-up and should I say the audit, which could be sometimes disappointing at some point and when we keep flagging it off and on. Okay, so just to what I'll do is I'll just use the slides on that. Okay, so I'll just be telling you this. It's a bit more interactive. Tell you, we started off just before the COVID pandemic struck us, and then it kind of settled down in a zombie mode, doing nothing. We had candidates, we had the implants ready, we had the money. Just a disclaimer, all the surgeries done here were all non-funded. That means not the government aided. So the motivation of the parents was a little bit extra. So they knew that they were putting in a lot of effort, not only finances, also their entire day-to-day living, a 24-hour panel, and so many kind of counseling sessions I've had with the parents, the possible candidates themselves, as well as my team here and Mr. Rajan and Ramesh and company, everyone. Next. So, so this was the initial part. Just great. It is just for a little knowledge that how I was lucky that all the implants done here, I was able to do the minimally invasive, the perimodular implant, which is probably less traumatic or atraumatic, the slim modular, which hugs the cochlea, and we were in a good shape. Luckily, I had a little training also on this, and that helped me to get that. It's not easy because this is the highest end of, not to brag, but the first perimodular implant in the country was done at MGM. And I think one was in Singapore before that, and this was probably one of the, for ANS, this was the first in Asia. Go to the next one. I just wanted to tell you how I don't do the bariatric or the suprametal, classical post-hypnotic technique, which I've learned. I'm sure the ones from Ramchandra, you've seen me go bilateral there, but simultaneous bilateral, all the patients that I've done here are bilateral, and that is something which is the first one, 2020, amidst the pandemic, amidst all those aerosol generating procedures that we have to take care, and everybody was around, and that is the kit that you saw the first one that I did, when the whole world was actually washing hands day in and day out. Next. So this is something I'm going to play just for. Now, this comes to the point where we should understand how the age of implantation matters a lot. Now, this girl on the left, I don't play. This girl on the left is on Danica, like telling the name. They waited and waited and waited. In spite of the fact that they were diagnosed and motivated for a CI long back, yet they waited for 2-3 years. So that was nearly 4.5 years when I did this. So at that point, you see, well, I need the sound. Where is the audio? Yes, audio is not there. This is part of the post-operative ABT. She has got communication. Look at it. Because this is exactly what Nisha was saying. Critical period of sensitivity. From beyond that, the triangle level has to catch up. So I'll run it again. Strength, the intelligence there, the synaptic complex, the prefrontal gyrus, everything is slightly mismatched. The triangle definition may be a little delayed. Whereas this girl Faria, let's see. Girl started very actively over this was after the I think this was the age of 2 years, 2 months or something like that. And doing exceedingly well. Now come to this. I wrote star performer because this is the youngest that I've done here. 1 year, 2 months. See now after 1 year how she just 1 year post implant. This guy has got this way. This was recorded yesterday. All
Okay, so who is the best friend in your school?
The reason why the question answer section was there because they need not see the eye close. They need to hear and then respond. You can see the difference with the patient, with a kid or a candidate who's had a fantastic, motivated parents. By the way, just to tell you, this guy's mother tongue is my mother tongue, but he cannot learn the mother tongue. So me, you like it's a different matter. Sometimes they say my mother tongue is English as well. So this is one of the staff performer that is having my experience. And it's going with the past. If I have to tell you the experience that I've had in the past, I think probably this boy will be the second best in my career of nearly 450 plants. Now look at this. This is the one we are talking about, the ANSD girl who initially started with hearing aid, some improvement. Language acquisition is wishy-washy, not too much. And then after the implant, we can see the difference. So very old. Same areas there. You see the point out. It's the first day of mapping. We go behind the patient, and then she raised her hand. And it was so endearing to receive a birth message. She calls me Sanjeev straight away. With no respect, or that is the respectful way that they call straight away. I think this, can you just put it in a higher volume? Quite intelligent intelligible speech, very well integrated, which was never the case when she was diagnosed. So why that happened? Discrimination was poor, and he said that the speech discrimination is really required. And post switch on, we saw a lot of responses. It's still a controversial topic to talk on ANST. Whether Cochrane run is the go-to procedure. Sometimes it may not, but you have to take the gamble before it's too late. Before the scavenging happens, as you put it very politely, pruning. Now comes the most interesting part. This gentleman is the auditor, all India auditor of Axis Bank. Can you imagine what kind of pressure situation this gentleman would have been? Oh, I've already written there for 15 years he was on hearing aid, and then came the wonderful COVID-19 virus. Everybody was masked, and he had a terrible time communicating not only his colleagues with his online platform when people started talking. Even without the mask, he was not able to communicate because as soon as screen presence, he didn't have much to look up and see what next he could do. Now,
I'm I was perform very fast for many years. I had been using it, hearing aids of varying and increasing power for past 10 years. And finally, some stage where no hearing aid was hearing loss. I was not able to carry on the conversation with you guys. I was not able to speak to people on the phone. So, generally, I was finding it very hard to manage in my personal conversation. I met Dr. Case. He advised me to undergo bilateral college after afterwards, I also went through biotherapy, wherein my brain was trained to recognize parts which are not heard from long. Surgery is to restart condition in mobility and able to take again.
so just to tell you how much it has changed his life. So at MGM, just to have a recap, all across age groups, we've seen 1 to 2 months, 2 years, and unfortunately at the 4.5 years, 12-year and a 58-year-old. Well, these are all for the surgeons to know that skin flap measurements are very important and atraumatic insertion. All these are extremely important to, this is like to just let you know that cochlear implant science is here to stay. It's a proven art of the science of the cutting edge technology. We're improving with each passing day. So there's no two ways about it. It's how we regulate our entire candidacy criteria and try to pick up the right candidate so that outcomes are like, objectively measured for others to look at, and even the patients are little benefited. Needless to say, it's we can say, oh, we go do a cochlear implant. It's not that easy. We have the error of margin of error is just that much, hardly a millimeter here and there. You can have a patient hear well, but you might have a facial palsy, you might have a complete disbalance and a ataxic dead throat if you're not very sure. And sometimes the surgery might be successful, so to say, but you see the electrodes are in a different anatomy. There is no two ways about the fact that you need to have very good knowledge of the intricate anatomy of the temporal bone, which is one of the most difficult master. So with all that we have done here in MGM, so in the annual conference of the CG, that is Cochlear Implant Group of India, almost every year, we have some kind of scientific presentations from the department. These are some of the ones which are in the process of publishing also. Thank you very much. That's the team that at the moment present here. And would like to be a little interactive. Very happy to have a few of my colleagues here, ex-colleagues from a different institutions coming in. Thank you for placing some words from you, Dr. Nataraj and Tirvakis, three of them. But please.
Very nice to be
That time is Pero from your side.
Yeah.
Full name is Tirvana Karsu, Tirnao Karsu.
Very nice to see different types of cases, right from the field in the have the right. We generally deal with the hits. But even that we can give to ourselves and we change the life. Been suffering for many years. Yes.
Your words.
I request you to conduct more programs like this. So it will be very interactive, but it will be more like a CME also. That's like a CME. Same thing which you have been doing it more often in the restaurants.
Thanks for coming. Any questions? Any queries? Nitya ma'am?
A very nice presentation, sir, and happy to see that you've taken so many patients for bilateral implantation, which is so difficult actually. It's very good job.
Talking of bilateral, let me tell you, it's not about balancing. That's a nice word. Being balance. But after having a short stint with
I think it's cost practice.
that is why I started with a disclaimer that I'm here with a totally non-funded one. In fact, Arun would be knowing, even in Amsterdam, even though we have a government scheme, the bilateral were done only for the non-government schemes. You remember the ones who could afford. Very difficult for funded scheme to have number one. Second thing is, when I worked with Tom Rowland with he was on the view that really hit me. If you want to spend money from somebody's pocket, you spend money from the other pocket also, because you will get only one chance. Only one chance to make sure that they get good sound localization, binaural hearing, the speech language acquisition skills, much better. In fact, there are a few unilateral I've done here, they're waiting. But collecting money, waiting, and the period of deprivation, what she said, when you have the scavenging happening at the synaptic levels, you will never get that kind of jolt with the neuroplasticity which we're talking about. So we need to have that. I know it is, and I was very lucky to have an access to these patients who could afford the best. So they always wanted cosmetic of the year, nothing, no wire here, there. So I was also happy. Surgically, we had to be a little more challenging because they're all very slim. One mistake, you're not very well job. Others around, not around. Yes, Vijay and Arun, little bit. First, Arun, you have to tell your experience there.
Very happy coming here, sir. I was able to come through right from the anatomy, physiology, the mode of hearing, and up to the advanced case levels, everything. I was giving a total pressure for everything from scratch.
Your experience then, and you assisted me, if I remember right.
But bilateral, it was still a very good, interesting topic today. That and what.
Vijay.
Happy to see extremely good outcomes across all age groups and peaceful. If I have a question, what is the
Roll on to this cross and leg cross. That's what Dr. Deepti mentioned. So the cross definitely is a first go-to. Unilateral, completely, moderately severe deafness. You don't cochlear implant. Single side deafness definitely crosses the number mark. It's a controversial thing. Why do you want to implant such patients? Only when they are very sure of the fact, some people don't like it. So the hearing aid will be on the side of the better ear. So that to convince a patient, again, it's a little often you have to tell them, no, that is a functional cochlea. That is going to take over the defective cochlea of the opposite side, and then they would speak and localize and all that. It's not easy. Whatever habits we have, it's difficult to change. Correct now? Okay, so yes, any audiologists, senior, I actually do not know them. If you can tell somebody to throw light on specifics, it would be nice. Or the senior that intimidated, I'm not really sure.
So I have a question. What's your minimum age that you do by?
Okay, I will tell you, here it was 1 year, 2 months. But in my life earlier, the youngest I've done is 9 months.
What is the youngest allowed?
9 months. Youngest in the in India, I think Amit Kishore has done 9 months something. So when I did the now I looked at it. So I'm not the first month, so that's okay. But I'll tell you the difference. I think after I've done 1 year or something. Less than 1 year, 11 months. So the difficulty is the surgical part because the scalp bone is so thin. So that time we didn't have the autoplan software. Now we have the software to know exactly where you have the thickness, the calculator, and how far is the dura. You can just press fine and then put it down. Nowadays, that time we didn't have these implants which are so thin. I mean, the thickness was very real, budget was real thick ones. That's all changed.
Because of the surgery.
Which
That you can't go below 9 months because of surgery.
no, the head control has to be there. So head control won't be there. You have the continents not fused, and the bone is, you have to have an area where the implant has to sit. So the bed of the implant is something like you make a small crater and you put some structure there. I mean, the implant bed has to be made. So if the bed itself is so thin, you can't go beyond it. You go to directly go to the dura, and then a little leak of CSF and all that. You don't want anything. So usually the skull bone develops around that area when it is around 9-ish. So ideal time to implant. Ideal time to implant is 1 year to 1.5 years. That's the best because you have a small time lag for the hearing aids to actually give the auditory input and also find out whether they're beneficial or not. And then you can get on. Thank you very much. So my vote of thanks here will be, thank you very much for coming over and being a part of this show. On a World Hearing Day, it's very significant to say that, it's a commemorative audience and topic as touchy as this. I'm sure some points people would have taken from this. We have to keep doing it over and over again. Just one word of caution. Once you're in this program, the patients or the candidates or the family of the cochlear implant, they latch on to you for life. And this relationship is much more difficult than even what we experience at home. Because they're extremely nagging. And they, for any small fault, even if there is a little change of a cable here and there or a battery missing or somehow the signals are not happening, they straight away so it's very difficult. I'm sure Ramesh knows about that, how difficult it is to get to the needs and the aspirations of people around. All in all, it's a very nice program. And you're doing something, and such pleasure I got yesterday from this Aravinda, believe me. I never expected this kind of thing, because the parents themselves, I know how much difficulty we went through, all sorts of programs. They wanted the best, but what is that, PICO now? Sorry, some donation drive and all that, they're trying, Aravinda, I'm saying. Yes. But they wanted the best, right? So, something like that. But, they sold their land and everything, they wanted everything for the kid, and so wonderful to see that, this kind of thing. Happy to share it on. Thank you very much. I hope he is there or not, he is there. Okay, so please join us for tea, and then we will. Thank you very much.
Thank you, sir. Thank you so much for sharing your experience. We're truly grateful for the knowledge that you've shared with us today. So let's all break for tea.
Brincar,